So my name
Great,
is
thank
V
you.
Shivamurthy. I'm a pediatric rheumatologist at Evelina London Children's Hospital. Thanks to Catherine and Katie for inviting me to do the talk. Why was I chosen to do this talk? No idea. Um, but one reason could be that Evelina was one of probably the hospital that initially saw the cases and reported to the world saying this is something unusual with these cases. And the journey starts from there. So the title is Pediatric Inflammatory Multisystem Syndrome and the story so far. So a lot of this, what I'm gonna describe will be, as I said, is very descriptive because this is a very novel inflammatory syndrome and there's only so much we know so far. Whatever I'll say will be drawn from own clinical experience and things I've heard from other centers across the world. Um, so just a quick outline on the presentation today. So we'll talk a little bit in the background. We'll go through some cases, the case definitions. We talk about the management principles and the key messages. Hopefully that will fulfill the objectives. From my end, the objectives were learn about the PIMSTS through the case illustrations, case definitions, and the differences to consider, which is so important in the current era. Bit about the management of PIMSTS, the general principles, and when we talk about medications and drugs, to be aware of the side effects too. Um, so earlier this year, we went into pandemic, and UK went into lockdown in March of 2020, and it seemed to preferentially affect the adults with the acute SARS-CoV-2. In pediatrics, we didn't see much. In fact, we were seeing less cases coming to A&E or to general peds or to any specialty. So there was a bit of a lull for a few days, to maybe 2 or 3 weeks from the lockdown to mid-April, when we started to see some unusual cases in PICU that could not be explained by acute SARS-CoV-2 because all the results are coming back as negative. These children were coming in very sick into PICU. None of those could be explained by any inflammatory condition. What was different about this was people talking about, could this be Kawasaki's, could this be Toshida syndrome, and why is it so different? Because the typical age we would say Kawasaki's would be under 5, and usually typical full house symptoms, but sometimes you may have 2 or 3 symptoms. You call them incomplete Kawasaki's and treat them. But what we're seeing here were older children, the teens, very rapid onset of symptoms. One of the concerns we had was the delayed presentation because of the worries about coming to hospital, catching COVID, where people sitting at home for many days and presenting very late. But that wasn't the thing. This was short history, rapid onset of symptoms, which is not explained by infection or any of the systemic inflammatory diagnosis that we knew. Every child we come across, their swabs are negative for COVID. We could not explain. Across London PICUs, this became a concern. And then the alert went out. The kind of presentation that we saw were fever was definitely a symptom, but abdominal symptoms in about two-thirds of them, and other systemic symptoms. They're presenting in shock and rapidly deteriorate. The inflammatory markers were sky high. You look at the CRP, there was in 200s and 300s. You look at the ferritin in many thousands, but not macrophage activation syndrome or secondary HLH, but actually you ferritin in thousands. They used to come with deranged coagulation, high fibrinogen, high D dimers, looking very prothrombotic, um, and rapid deterioration in the first few patients that we saw. So 11-year-old girl, black origin. She came with 5 days history of fever, headache, neck stiffness, loose stools, abdominal pain. She had a history of asthma, eczema. What is to note here is the BMI was 34.8. Um, So if you look at, I don't know how well you can see the screens, you can look at the counts. There is what's striking in the full blood count is that there is neutrophilia and absolute lymphopenia, less than 1 are the lymphocytes, and the ferritin is in a few hundreds. And if you look at the troponin, is 200. The albumin is a little bit low at 33. CRP was close to 300. procalcitonin was 1.7. So she went on to PICU, initially treated with IV steroids, and then she went into tocilizumab. Sorry, she went into IVIG and the IV steroids and tocilizumab. Tocilizumab is a biologic which is anti-IL-6, so interleukin-6. So I don't, again, sorry, the flowchart looks very small on the screen. This is basically timeline, which is got a mismatch there. That we gave steroids, we gave the methylprednisolone IVIG and the biologic, and the CRP started to improve. And then she got better, came up 100 troops off PICU onto the ward. And then around the same time, another young male, 13-year-old, again slightly overweight, but this one had much shorter history: 2 days of fever, 1 day of rash, vomiting, and conjunctivitis. Another one who came to Fairfield Hospital noticed to be tachycardic. If I remember it correct, this mom took her son to a hospital because of the rash, because fever was only for 2 days. In A&E, he was noted to be tachycardic and hypertensive. So obviously, after the initial management, they got in touch with the retrieval team and transferred to PICU. And again, you can see the numbers. Sorry, it's again gone off the screen here. The lymphocytes I can read from the left side of the screen, 0.5, neutrophils of 7.4. The ferritin was 1648, going up to 1900, slowly creeping up. This is just the initial presentation. D-dimers are only 2.29, 2.14. Fibrinogen was slightly high, 6.9, 6.5. Again, the screen is a little bit of mess here. At the top, what you see is troponin 83 and the sodium. And then if you come down, all the way down, you see the pro-BNP, which is 1900, and then going up to 4400. CRP was 220, went up to 260, and then came down to 159 in that particular week. On this child, echo initially showed mild ventricular impairment and coronaries were bright, but a few days later there was a small aneurysm in the left anterior descending artery. Because of the initial hypertension, I had received some inotropic support. Again, the treatment for this one was intravenous immunoglobulin, IV methylprednisolone, and tocilizumab. Now, we saw about 70 cases between mid-April to first week of June, and kind of peaked sometime in May. In the week I was on, which is second week since the presentation, about 20 or 25 patients came in. Some of them were really sick. At one point, we had about 10 in PICU. So this is how sick they were. This patient that I'm going to discuss later came in a little bit later, sometime towards end of June, early July, I think. So he is 17-year-old who had rash, fever for about 2 weeks, worse in the evenings, twice daily spikes, cervical lymphadenopathy, nausea, abdominal pain, joint pain, and knee swelling. Now, I would have asked the audience the question, what are your thoughts at this stage? Now, I'm not sure how I will get the response if I ask the question. Katie, are you monitoring the chat box?
Yeah, I can monitor the chat box. Or you might even be able to see it, but otherwise I can I'll let you know.
I have to come off the screen and I don't want to mess the screen sharing. That's the reason. So if I put the question to the audience here, 17-year-old who's come with fever, rash, fever up to 40, going up for 2 weeks, worse in the evenings. And then when you actually admit to hospital, he's got twice daily spikes, he's got cervical lymphadenopathy, abdominal symptoms, joints pain, knees swelling. What are your thoughts at this stage? Yeah, somebody's suggested systemic Still's disease. So absolutely, one would be thinking of systemic arthritis or Still's disease. The difference here is he's 17, so you can't call him systemic arthritis. Any arthritis that is under the umbrella term JIA will have to have an onset before the age of 16. So we wouldn't be able to call him systemic arthritis. So he'll be more like adult onset Still's disease. You got to think about. So one possibility. Any other differentials?
I'm happy to read them if it's easier. Just let me know what's best. But we've got a couple of suggestions, including something autoimmune,
Yes.
toxic shock, malignancy, like leukemia.
Absolutely. I've got a smart audience here. So exactly were my thoughts. Put this way, being a rheumatologist, I have to be open in how I think I shouldn't be assuming everything as PIMSTS. And people are spot on here in thinking through the differential. Systemic arthritis or Still's disease, one possibility. Lupus will be another possibility. Leukemia, malignancy, always have to think, although slightly odd because the age, the ALL is usually between 1 and 10, but 17 never say never. A lymphoma could be another possibility because there's some lymphadenopathy here. Um, what was the other differentials they talked about,
Um,
Katie?
toxic shock.
Possibly, except the fever has gone on for 2 weeks. I'm not sure how often we see lymphadenopathy without much of a skin presentation, but obviously this one had a rash. So absolutely right thing to think about. We don't usually see knee swelling in toxic shock syndrome, but if somebody's edematous, hard to make out. So rash was maculopapular on examination, certainly had cervical lymphadenopathy. When I examined, he did have both knees swollen, wrists were tender, hips very painful to move. We did a chest X-ray that ruled out anything abnormal, meaning there was no mediastinal lymphadenopathy. Ultrasound was normal, suggesting there was no organomegaly and there was no lymphadenopathy that they could pick up on the ultrasound. Again, this is the disadvantage of having the online platform. But again, at this point, does the differentials change? Any responses? If not, I can move on.
No responses yet. And I'm going to say I would still have all those differentials, maybe.
Indeed, absolutely. So from the screenshot, you can see the numbers here. His vital count was high, up to 21. His ESR was high at 93. His ferritin, you can't see the full numbers. They went up to 20,000. The first one you see is 19,000 something. Um, then in the subsequent screenshot, you will see that his ALT was slightly elevated. CRP was high, albumin was low. CRP went up to 250 and then down to less than 100. The pro-BNP wasn't too high, and we measured interleukins too, which were interestingly not so exciting. So whoever said Still's disease, brownie points to them. When I first heard about him, I thought this must be lupus because he has fever, he has arthritis, he has lymphopenia, he's got a high ESR. Well, sometimes you can get high CRP too. But the Still's disease or systemic arthritis is again diagnosis of exclusion. After seeing him clinically, my the clinical impression changed from lupus onto systemic arthritis, stroke, Still's disease. Malignancy was still in the corner of my mind, but actually there was nothing to suggest malignancy. So we treated him with steroids and anakinra. Anakinra is another biologic which is anti-IL-1, and it is used in systemic arthritis or Still's disease when they have systemic symptoms, hyperferritinemia or macrophage activation syndrome. So although he wasn't full house macrophage activation syndrome, he did have very high ferritin, high ALT, other inflammatory markers suggestive of a evolving MAS. So third one, 3-year-old intermittent fever for a few weeks. Now, he also was referred as PIMSTS. All the patients I'm describing here were referred to us as PIMSTS in between April and June. So 3-year-old intermittent fever for a few weeks. Now, history wasn't clear. The reason why he was referred as PIMSTS is because that episode when he was referred to us was a fever of around 5 days. He had a rash, he had abdominal pain. He had been to GP in the recent past. He had some topical antivirals, thinking this could be cold sore, and he also had some antibiotics. Didn't get better. He was complaining of joint pain, fatigue, loss of appetite. And as you can see, white cell count was normal. Lymphocytes wasn't lymphopenia. Now this is actually different because if you look at the two sick ones we had in the first two presentations, they had absolute lymphopenia. This is more of a relative, although NIT was only 4. His ferritin wasn't sky high, but hovering between 900 to 1800. In the next screen, you can see fibrinogen was 5.65. D-dimer wasn't too exciting. His albumin was slightly low, around 33 to 35. CRP was high, but wasn't more than 100. In some of the PIMSTS patients, most of them we have seen CRP very high. In his case, it wasn't. So we were wondering what is happening with this one. And always in the back of mind, we had there must be something else going on here. But we couldn't find anything at that time. So we treated as PIMSTS, gave him IVIG and aspirin. Well, he was given IVIG aspirin from the peripheral hospital already, and then on the weekend he came, he already had steroids. When I saw him next day, he was better. On the Monday I saw him, so I thought maybe this was all PIMSTS still. Although something was unsettling in me, saying there must be something, we're missing something here. Towards the end of the week, he started complaining of limb pain, which was an issue before, and then it became more apparent as the week went. We looked at the blood film, everything was clear. We looked at the other side, repeat blood, nothing was indicative of anything of malignancy or alternative diagnosis. We thought, let's do the bone marrow, because in rheumatology we have seen children presenting with the non-specific symptoms and they had normal films. We have picked up leukemia either based on clinical suspicion, or you do MRI of the limb and there is marrow infiltration with a bright light up on the MRI. So he did have a bone marrow and he did have leukemia, unfortunately. But we managed to get the diagnosis sorted in that week for him. So we've been, you guys have heard how the story has been in the last few months. So we had the PIMSTS patients. We've had patients who were referred as PIMSTS but also have alternative diagnosis. But when we were grappling with the influx of patients towards end of April, early May, nobody knew what to call them. And through our experience of having seen a dozen cases or maybe a bit more at the time, we had to start to define the cases. And the first attempt was by our group as well as Pan London to come together, led by ID, to define the syndrome. So Royal College defined, as you probably are aware of, a definition which is most inclusive. Any child presenting with fever or blood suggestive inflammation and evidence of either single organ, multi-organ dysfunction is one first inclusion criteria, but they have to exclude sepsis or any other sepsis syndromes, and SARS-CoV-2 may be positive or negative. And then the rest will be all sort of appendices with the clinical laboratory and imaging markers. But the CDC is slightly different, where the Center for Disease Control from the US, which caught up with this inflammatory syndrome maybe 2 weeks or 3 weeks behind us, when the US started to peak cases, and they called it slightly different. As usual, North America wants to be different. They called it as multisystem inflammatory syndrome in children, so MISC. Basically, their definition of 4 categories. One is fever is a must, and then laboratory investigations very similar to what we had: high CRP, high ESR, high fibrinogen, high procalcitonin, D-dimers, high ferritin, high LDH. They even measured IL-6 in most patients. Even within a hospital, we didn't measure in the majority. And some centers in the country do measure IL-6 levels. There's neutrophilia, lymphopenia, and then when it comes to organ involvement, they said at least 2, whereas we said single is fine. And then any alternative diagnosis would be an exclusion factor. I don't know whether you can see the bottom end, any of the following, which is positive SARS-CoV or serology or contact with COVID. WHO definition also came where the age was slightly different to other two definitions, 0 to 19, but they wanted to have fever for at least 3 days. Clinical signs of multi-system involvement. Again, they said of the multi-system involvement, they have had to have at least two, whether this was rash or hypertension or cardiac involvement, coagulopathy or GI symptoms. As you can see, GI symptoms makes its way into all definitions, one of the key system that was involved in PIMSTS. Again, exclude any microbial causes and evidence of SARS-CoV-2 infection, either in the form of positive PCR or serology antigen, where there's available or contact with the individual. So we knew that this wasn't an active COVID infection because all the stuff serially come back as negative, no matter where you take it from. And then a few weeks into the presentation, we started to realize that this is more likely a post-infection immune-mediated phenomenon. What we realized at the time is many were asymptomatic or maybe mildly symptomatic, which is strange. Majority of them didn't have any significant comorbidities. What was striking is the ethnicity. The blacks and the Asian ethnic minority were the ones most affected at the time across London hospitals when we started looking into it. And then a majority of them had high BMI. So how do we manage? So we all had to come together. So it started off with ID and rheumatology working together. Patients coming to PICU, how do we manage them? And then obviously we need other teams too. Cardiology obviously look at the cardiac side of things. Radiology to support us with the imaging. Hematology to do with the thrombotic management, endocrine, because as I mentioned, vitamin D was low in the majority of these patients, particularly the ethnic minority. We all know vitamin D has some kind of a hormonal role and immunomodulation role. It was thought that whether low vitamin D is just making matters worse rather than helping here. So that's the way we approach MDT. So every week, every day, we would have MDT to discuss these patients. We would sit together, discuss every single patient's come through the door or admitted or has been discussed from other hospitals in the region. How do we tackle it? So this is where rheumatologists had a role because yes, you could manage this Kawasaki's, but actually this is much more aggressive form of disease where they come in, they rapidly deteriorate and have significant cardiac or coronary changes. So now we are involved in some of the Kawasaki's disease, particularly the refractory or atypical ones. We know how the steroids and the biologics may make a difference. We have the experience, expertise in managing vasculitis, lupus, all of the multisystem inflammatory conditions. We have the experience of managing macrophage activation, hyperinflammatory conditions. So we got to draw that experience and then bring management into this condition, which is an hyperinflammatory post-COVID phenomenon. There is a vasculopathy, there is endothelialitis, some form presentation similar to Kawasaki's with significant morbidity mortality risk. So we knew it was unpredictable course. We were still trying to understand at the time. So we brought in the use of IVIG, steroid, and biologic into management of this group. So in most patients, almost all of them, except for a handful, had IVIG 2 gram per kilo. We knew IVIG alone wasn't enough, so we would bring in IV steroids pretty much in the first 24 hours. We used to give a slightly higher dose before. Towards the later part, we started to use 10 per kilo of imethylpred, more so for those who are in shock or acutely ill. And then those who didn't are still progressive in terms of inflammation and cardiac dysfunction or multi-system involvement, we would bring in biologics. Now, choice of 3 biologics: infliximab, where the use has been from refractory Kawasaki's. Tocilizumab anakinra has been used in the adult in the COVID trials and in the ICU patients. We have experience in using anakinra, tocilizumab in macrophage activation too. So those are the 3 biologics at our disposal. And then for prothrombotic state, it was use of low molecular weight heparin because we saw the fibrinogen was very high, D-dimer was very high, and then low dose aspirin. The challenge is still continued. Do we have the right diagnostic criteria? Because yes, we know something about this, but what is the best diagnosis? Are we clear what we are dealing with? Is this the best definition we have? But we need to look at how to redefine. Do we have a scientific basis? Because the RCPCS definition is quite inclusive. How do we have a scientific basis? Meaning, is there any way we can definitely prove that this is to do with the SARS-CoV? Now, two-thirds to a little more than two-thirds had the antibody positive results. In the rest, we couldn't. Now, that could be because, yes, they've had exposure, but the antibodies don't float forever. So by the time we test it, doesn't mean they're already gone. Again, the majority of them were either asymptomatic or mildly symptomatic. What we know is a carrier, it could be carrier, it could be mildly symptomatic, but you won't necessarily mount the same response with antibodies. Um, so is that the reason why we didn't find antibodies in some of them, or did we just have some hyperinflammatory syndrome presenting to us in the COVID era, and we call them PIMSTS? Investigations, there's plenty of investigations we had been doing, but none of them were true biomarkers for this condition. We didn't know how to interpret. We had procasted over 100 and didn't really translate it to severity. We had procastin of 10, but actually still continue to have coronary and cardiac changes. So none of the biomarkers were by themselves of any help. Management, how do we draw the management plan? This is total evidence-free zone. We were using IVIG, steroids, and biologics, but did you need all three drugs or any two of them, or is one better than the other? Um, but when do we actually bring in biologics? In the initial phase, we were reactive, saying if this one got unwell, then use biologic because of the cardiac dysfunction or aneurysm. But was it the right approach? We thought let's go proactive and bring in biologic sooner, like within 48 hours, to see if we control the inflammation by bringing the fever down and CRP down, can we prevent the progress of the inflammatory changes? But anything that we use, we got to think about the benefits and the risks. So IVIG is not all safe in every patient. So it has its own issues. IVIG, as you guys know, is pooled immunoglobulin pooled from the pooled donors. That itself could be a risk, but it itself could be prothrombotic. It can lead to thrombosis, and we already know whether acute SARS-CoV-2 or post-COVID immune-mediated phenomenon, there is pro-thrombotic challenge. And if we bring in IVIG, are we making matters worse? We know that hepatic dysfunction, hypertension, hypothermia is all known side effects. Aseptic meningitis is a risk. We saw a lot of children quite irritable during the stay and post-treatment too. Is it because we know Kawasaki's can give you aseptic meningitis? If PIMSTS is worse than Kawasaki's, then there is that risk by itself. We didn't know if that was a disease itself or the IVIG or the steroids bring the behavioral challenge. Hemolytic anemia is also a risk. Steroids we used quite a lot. Hyperglycemia could be transient, is a risk, but in some who are predisposed and those who have high BMI, it can trigger the onset of diabetes too. Hypertension, a few of them were hypertensive enough to be on antihypertensives and go home on antihypertensives. The risk also remains around posterior reversible encephalopathy syndrome that we tend to see sometimes, which is to do with the steroids and use of steroids and hypertension. Although we had suspected one or two, none of them were proven to be PRES, but the risk is there. When it comes to certain conditions, whether you're talking about sickle cell disease or something similar, they pose a much greater challenge. We had one where he was in a PIMSTS. He came in very vague with fever and inflammatory. We also had to think about sickle crisis and osteomyelitis and infections, everything. Ruling out those things, we went into treating as PIMSTS. He did have the treatment. He did get better. He did develop coronary changes, but maybe less severe, hopefully. But he did have significant CNS side effect. So that's a challenge in those patients. Now, steroids could also mean weight gain, behavioral challenges. So, after going through this journey, what are the messages that our audience here would like to know? Now, I didn't have any chance to send a survey and ask what you guys wanted to know, what are the messages you wanted, what are the objectives from this session. But from my perspective, one thing has to be clear that this is a novel inflammatory syndrome. We're still making every attempt to learn more about it. Fortunately, things have quietened at the moment. We're not seeing that many. We're scattered few. But one has to remember now from the case illustration that this is a diagnosis of exclusion. The clinical acumen, the clinical approach has to be a strength where you listen to the story, listen to the history, take a thorough history, do a thorough examination. Now, I teach my juniors the 3I, which is anywhere, anytime you come across an inflammatory presentation, think of 3I, which is infection. Always think of infection as the most likely possibility. Now, if you go back to Kawasaki's, one third do have an infection, but also can have Kawasaki's. Think of inflammatory. Now, looking back at the adult onset cystitis patient, now as soon as I heard the story, they referred him as PIMSTS, but he was my thought he was going to be lupus because lupus gives you fever for that long. It can give you arthritis. It can give you lymphopenia. It can give you high ESR and a high CRP. It can give you arthritis. It can give you rash. It can give you cardiac involvement. It can give you gut symptoms. Why couldn't this be lupus? Again, adult onset Still's disease too, or systemic arthritis if under 16, they are all mimickers. Vasculitis. Now, whether acute SARS-CoV-2 or a post SARS-CoV-2, it is a vasculopathy end of the day. Um, so it mimics all the symptoms of vasculitis. We don't be missing vasculitis. Um, we're talking about small vessel vasculitis, such as ANCA-associated vasculitis, where it can affect the lungs, the kidneys, respiratory tract, can give you skin and fever and joint involvement too, as well as myositis. We talked about systemic onset JIA, inflammatory bowel disease, fever, abdominal pain, young boy or girl, why couldn't this be IBD? Other centers have picked up IBD as well. Now, we illustrated one case of leukemia. Always think about possible infiltration, malignancy, leukemia, lymphoma as a possibility. Surgical. Now, here's the interesting bit. Fever and abdominal symptoms have been quite a dominant symptom in a few. And when you do radiology investigations, we produce a paper in radiology where they have findings of colitis, they have mesenteric adenitis, they do have non-specific changes in the gut. So gut and mesentery is involved to some extent, but one has to be very clear. We have seen both ends. One is who had appendicitis and then came to us because they were not getting better. And also they came to us as PIMS and we picked up there's something not right here and did have appendicitis too. So it's not the easiest one. When you haven't seen it, it does pose a challenge. Some of you may have seen PIMSTS in your peripheral hospitals or tertiary centers. When in doubt, always phone a friend. Now that could be ID colleague or rheumatology colleague, it doesn't matter. Always run the case fast, but do the basics first, where you got to make sure patient is safe, ABC. Now, always one has to think of infection curve with antibiotics. If hemodynamic is stable, if you're worried, IVIG may still be a safe bet, but this is based on the approach right now. In future, it all may change. But make sure if you're going to do IVIG, take bloods for serology, whether this is for infection serology or for rheumatology workup, because once you give IVIG, any results post IVIG will be very difficult to interpret. Um, Familiarize yourself with the clinical presentation because rheumatology diagnoses are rare, but even PIMSTS is much rarer. So keep your eyes and ears and everything open. If you have an echo facility, then that might help establish the cardiac dysfunction sooner. Obviously, in shock, you have to do what basics you have to do in managing the shock. But what I learned from my PICU team is that this shock is not the straightforward shock management. So contact a triple team of PICU sooner. So what next? When is it going to be ever in normal? I guess it is a new normal we'll be all facing in future, isn't it? How we operate is all changing. Whether we Look at the way we run the clinics or run the units. It's all changing now. The whole world is covered in mask. It could be chin masker covered in the mouth and nose. It doesn't matter. The mask become the routine here. That might be our life. Um, what's the future? Are we going to see lots of PIMSTS cases or MISC, whatever we call them, come September, October? Is that what's going to keep us busy? I really hope not. Had enough. Um, if we see them, how do we redefine them? Management has been variable across the centres, whether London or Birmingham or Newcastle or Leeds. There is slight variation in the approach because, as I mentioned before, we don't have um, evidence to say one works better than the other. But people are trying to do the best to collect the data, look at the evidence. BATS is best available treatment approach, which Mike Levine is trying to collect across the world. Clinical trials have been proposed. If you ever go into, you may have heard recovery trial, which has been adapted for PIMSTS and pediatric patients. There's another trial also delivered, which will be complementary to the recovery trial. So if ever we're going to go, we probably have to find a way of extracting evidence that's going to work. Is this going to be with us in the future and become another a condition that we all have to learn and learn how to manage? Is this the end? We don't know. Great. I'll stop sharing now and I'm open to questions. I don't know how people want to do. Do they want to ask or put in the chat box? How do they want to do it?
People often write in the chat box, but I have a question and then I can keep an eye on the chat box if it's easier for you.
Absolutely.
Which is that you mentioned that you're not seeing very many cases at the moment. Is that right?
Absolutely.
Do you think, I mean, do you think that gives you an idea of like a kind of temporal relationship with COVID, or is it too early to say, or?
It probably is temporal because we had the peak back in March, and then 4 weeks later we started to see the cases. So the one, if one were to go with logical thinking, you are exposed to COVID, and then you develop antibodies 14 days later. When I delivered a webinar to Florida team, they said the immunologist over there said 14 days is how long it takes for the antibodies to form and be present in the system in the blood. So if you look back, it's about 4 to 6 weeks is the time interval between potential exposure, maybe to kids developing symptoms. So if we had the peak in March and cases coming in through April, May, did explain as the lockdown happened, less as we actually plateaued and then went down, the cases also started to settle. Now, what is unusual is that every 1 or 2 weeks the pattern changed in the kind of presentation we saw. What we saw end of April to early May was different to what we saw towards mid-May, towards end of May, early June. What differently was seen in the last few weeks is infants who we would like to call them as Kawasaki's disease have been coming through a little bit more for the season, and they have progressed aggressively to developing coronary changes too. So indeed, it would say this is temporal correlation. So which is where we all kind of keeping our eyes and ears open for the near future when comes September, October, when people start going back to work, going back to school. Doesn't mean we're going to have a few more cases and there's going to be another wave of these cases.
That's really interesting. Thank you. So you're kind of suggesting that there might be a slightly different inflammatory response that occurs slightly later after exposure, explaining that different pattern over those weeks.
I guess each individual immune system plays differently, isn't it? Because what will be interesting to know is within rheumatology, in the hundreds of inflammatory patients we have in our center and across the country, maybe across the world, we haven't seen a single one of them coming to us with PIMSTS, and not even acute SARS-CoV. So some of our kids are on medications such as biologics and steroids, and some of them even had cyclophosphamide and other stuff. Uh, but that was a worry at the beginning, and none of them have come back with any. Um, but how did these children, who majority didn't have other comorbidities but actually developed this syndrome? So something the immunogenetics is playing a role here, and each one in the hyperinflammation either presents as what would be as PIMSTS sick one, or inflammatory, like they have macrophage activation or some odd inflammatory response, or the younger ones could be Kawasaki's.
That's so interesting. Thank you.
Welcome.
There's one question in the chat. I don't know if you can see it or you'd like me to read it to
Yeah,
you.
I can see. Is it to do with the thrombocytopenia in prothrombotic stage? And that's the question from Young. So yes, is it usual to have concurrent thrombocytopenia in prothrombotic stage? If yes, how to balance the platelet transfusion and use of low molecular weight heparin? Now, the thrombocytopenia, what we see in the initial ones, is because of multi-system failure, multi-system involvement, just like you would see in DIC or macrophage activation syndrome. When there is hyperinflammation, you do see thrombocytopenia. So that is one explanation of thrombocytopenia. Um, the prothrombotic stage is nothing to do with the platelets alone. It is to do with the vessels, because if there is endothelialitis, if they have some kind of vasculopathy and you have high fibrinogen, you are hypercoagulable, and thus the risk with the prothrombotic. We have seen thrombotic tendency in a few, and thrombosis in 4 or 5 patients. One of them had thrombosis, sitting a big one in his heart when he came to us. Another one developed thrombosis maybe secondary to cardiac dysfunction. 1 or 2 patients, when they tried to put an arterial cannula, they would see small clots, and that is how prothrombotic they are. So we never use platelet transfusion in these children because you got to treat the underlying inflammatory conditions. So even macrophage activation syndrome, which carries high mortality morbidity, they will have platelets down in the boots, but actually, um, unless they're bleeding, we don't transfuse platelets. We go with the treating the underlying process, and then once they get better, they recover the platelets. Um, it's a challenge in PICU, so PICU team might be the best people to explain to you how do they manage the ECMO circuit or ventilation and low molecular weight heparin versus heparin. That's a different question to PICU team, because we target the immunomodulatory. We never go into details about heparin and platelets. I hope that answers the question.
I think that was very clear. Thank you.
Any other question?
I had another question. I'm so sorry to keep asking. You were saying you're seeing more Kawasaki disease in younger children coming through at the moment. Do they have the same sort of comorbidities, or like, not maybe comorbidity is the wrong word, but the same kind of profile as the children presenting with PIMSTS? Do you have the same kind of ethnicity, high BMI, low vitamin D, that kind of thing, or are they just your kind of standard younger patient?
So the inflammatory trigger has been different in the sense. So we would have seen Kawasaki's trigger in spring and sometimes in autumn too, but in the summer it shouldn't be that many cases. The ones we have seen as Kawasaki's are the younger ones, under ones, or toddlers like 13 months old, 15 months old, and I don't think the ethnicity was as defined as the PIMSTS. We haven't had that many numbers to compare. I don't think it was defined by ethnicity because these are very young. The one of them 3 months, one is 8 months. Um, Even if it's Kawasaki's, the risk is much higher the younger you are. Under 6 months, risk is higher. If you present at the age of 2 or 3 months, you can almost guarantee they're going to develop aneurysm. So I have seen even well before COVID, a 2 months old, a 3 months old who are very sick and develop aneurysm. Something, I don't know what it is, the infants, they're at risk. But coming back to question, uh, is it defined by comorbidities or other risk factors? No, I don't think so, because you don't expect a high BMI, that big a deal in the infants. And I don't think it is by ethnicity either. Now, none of us have looked into much more detail, but it wasn't that obvious.
Great, thank you.
You're welcome.
Um,
So I hope it was helpful to the audience. I've been It'd be great to hear the feedback. One is not just what you learned today or how it went, but actually, did it meet your objectives? What would a trainee want to learn from it? And also, I don't know what level of training you guys are in. Um, is it what you were hoping to learn? Did it give you the answers that you were seeking? Is the question.
yes, if everyone could remember to give feedback, I've put the link in the chat. That would be really great. And thank you so much for your time today. It was really appreciated.
Not a problem. And thanks again for inviting me, Catherine and Katie. Enjoy your weekend.
You too. Thank you.
Bye bye.